Hi, this is Tracy Newman, Washington State University College of Nursing. This is Nursing 400, Research and Informatics, Fall of 2014. This PowerPoint presentation is on evidence-based practice avoiding complications during dialysis. In older adults with renal failure, how does early rapid ultrafiltration compared to intermittent ultrafiltration with fluid return affect muscle cramping during dialysis? The PICO question addresses a serious concern in providing effective dialysis. Excessive fluid can not only put additional strain on the patient's already damaged kidney, but the additional fluid puts excessive strain on the heart, leading to heart failure, increased risk of stroke, and the damaging effects of chronic hypertension. Often, fluid removal complications are managed after the signs and symptoms appear, and it can take up to 20 to 30 minutes to alleviate the signs and symptoms and bring the blood pressure back up. During this management stage, fluid is not being removed and precious time lost. The article that I found to apply to my PICO question was called Preemptively Pausing Ultrafiltration to Minimize Dialysis Hypertension by Bradshaw, Ockerby, and Bennett. Their research question was, can preemptive pausing of ultrafiltration based on changes in mean arterial pressure prevent episodes of interdialectic hypertension and the complications such as cramping associated? The support for this study is that it's a small study, but it does provide evidence indicating that stopping the ultrafiltration when the mean arterial pressure reaches a preset low level does reduce the incidence of hypertension. In fact, their data analysis showed a 61% reduction. The limitations of the study is that, again, it's small. It is a level 4 on the evidence pyramid, and there are some bias and confounding factors that were apparent. The decision is that the research supports further study. At this time, a randomized control trial is warranted to confirm the findings in this pilot. Validity for this study was the patient population. Validity refers to whether or not the findings were the result of research that conformed to accepted scientific methods. The appraisal tool that I used asked several questions in order to determine this information. The first being how the cases were obtained. In this situation, the patient population ages ranged from 37 to 82, which indicated a wide variety. But the patient population also contained a majority of men, and therefore the results indicated some bias in gender. Also, because the study was conducted at one dialysis center, there's a good chance that everybody came from the same geographical area, which probably meant there could be outside factors that influence their health, for the good or for the worse, that could have influenced this in relation to how it's applied to the general population. The second question for validity is, where are the appropriate controls selected? In this study, the staff that cared for the patient was consistent during both the exploratory phase and the intervention phase. However, because this was a pre- and post-test study, meaning the first stage was just observing patients having dialysis and recording episodes of low blood pressure and complications, and then the intervention phase was applying the mean arterial pressure protocol. It wasn't a randomized control trial, so it wasn't as rigorously monitored. Bradshaw, Ockerby, and Bennett reported that 2 of the hypotensive episodes that occurred during the intervention phase might have been prevented if the staff that had intervened had done so per the protocol. They didn't, and so those 2 incidents might skew the data a little bit. The final question on validity from the appraisal tool is whether or not the data collection methods were the same for the cases of the controls. In this case, they were not. During the exploratory phase, the data was recorded by the study architects, and during the intervention phase, it was recorded by the nursing staff. The other questions to answer regarding whether this study is warranted for further research was reliability. In this case, the number of incidents of hypertension during the exploratory phase was 20, and during the intervention phase was only 8. So the focus of the study was a preemptive action to prevent that hypotension, and the results supported a 61% reduction when using the mean arterial pressure intervention. There were multiple comparisons of the data. They did a simple frequency and a chi-square analysis. Chi-square analysis is used to compare actual collected data with the data that was hypothetically expected. In other words, it's the difference between what was thought would happen and what actually occurred. So was it supported by chance, or might there be other factors that were influencing the results? By analyzing in this manner, the researchers can tell whether the reliability of the numbers is considered influenced by outside forces. In this case, however, they didn't report the results of the chi-square analysis, so there's no way to tell whether the numbers were supported or not. Confounding is also possible in this study. Behaviors during dialysis were not prevented or monitored and might be different in each phase. What I mean by that is that patients on dialysis do a lot of different things. Some of them eat snacks, some of them eat meals, and those can increase hypertension and episodes of complications. So unless you're going to prevent that or make sure that it's the same in both cases, you might be influencing the results. The search terms used were muscle cramping, interventions, hypotension, interdialectic hypertension, and hemodialysis, and nursing. I used 2 databases and search engines to find this study. First was CINAHL. It's a research tool for nursing. Provides access to over 1,000 nursing journals and care sheets. I used the CINAHL heading search to build on my key terms. It did not lead to an article using cramping as one of the key terms. I had to expand the search to include hypertension and complications of dialysis. The other database was PubMed. It's a database for the National Center for Biotechnology Information. It's a government research into molecular biology and related fields. It's a division of the National Library of Medicine. I used a MESH, or a medical subject heading search, which is a vocabulary thesaurus used to index articles to build your search terms. One of the other articles that I found was titled Hemodialysis-Related Cramps and Nocturnal Leg Cramps. What's the best practice? This was one of the only articles that I found specifically addressing cramping, but it had more to do with cramps outside of dialysis. The research question for this study was, are muscle cramps during dialysis and nocturnal muscle cramps related, and what's the best practice? The support for this study was that it included a review of many articles specific to cramping. The review found that there were several treatments that showed success other than fluid removal variations. So it didn't really address my PICO question either, which was specifically in regards to fluid removal. The limitations of the study was that most of the literature reviewed were conducted with very small sample sizes, and a lot of it was older. Very rarely was a larger study conducted to follow up the initial findings. The second or third article that I found was called Sugar or Salt, the use of 5% dextrose in the adult non-diabetic hemodialysis population, by Raymond, Miguel, and Chow. The research question that they proposed was, is a 5% dextrose solution better for reducing interdialectic hypertension and related symptoms such as cramping than normal saline? The support for this study was that it was unique in that it's the first to compare both isotonic solutions. Prior studies compared hypertonic to isotonic. The limitations of the study was that it had a small starting sample, and that was reduced even further through loss of participants during the study. My analysis of the article that I chose shows that there is a possibility for practice change. The practice change implications were that most modern dialysis machines do support mean arterial pressure. When they take the blood pressure, it is reported. Pausing the dialysis based on a mean arterial pressure limit is non-invasive and requires no medical administration. And making the determination on when to pause ultrafiltration is the function of a dialysis nurse. So in cases where insufficient fluid is being pulled, there's no reason that trying a preemptive pause based on falling mean arterial pressure couldn't be used. However, in order to make an evidence-based practice change in dialysis procedure, research should now be conducted in a randomized control trial to verify these pilot study findings. That's my presentation. I appreciate your tuning in. Thank you.